Good morning. Welcome to the 2023 John Suydam Kuhlthau Bioethics Conference. It's a special privilege to welcome you to this year's conference, focusing on diversity, equity, and inclusion in healthcare delivery. The John Suydam Kuhlthau Bioethics Conference is sponsored by New Brunswick Theological Seminary in collaboration with Rutgers Robert Wood Johnson Medical School, the Robert Wood Johnson University Hospital, RWJ Barnabas Health, and St. Peter's University Hospital. It is made possible through the John Suydam Endowment, which was established by a generous donation from the late Honorable Judge John Kuhlthau and his wife, Dr. Carol Kuhlthau, who continues her support. Today's conference theme, Diversity, Equity, and Inclusion in Healthcare, Equitable Care is Ethical Care, affords us an opportunity to reflect on providing quality, equitable healthcare to all people. As I was doing my research on this topic, I came across the work of Robert Wood Johnson Foundation, which states, and I quote, "The COVID-19 pandemic called attention to and worsened the impact of racism and inequality in the lives of people of color and residents with low incomes. As New Jersey turns to recover and repair, a revitalized public health system is crucial to making sure history does not repeat itself," end quote. This presents us with the urgency of addressing those disparities and champion diversity and inclusion within the field as never before. Our task today is to engage in thoughtful dialogue, learn from one another's experiences, and emerge with actionable solutions that will make a tangible difference in the lives of patients, providers, and communities we are called to serve. To assist us in our deliberations on this issue, we have invited two highly capable scholar practitioners who have given serious consideration to this issue. We welcome Dr. Dula Pacquiao and Mr. Jeff Grosser. We are profoundly grateful to have them as our presenters. We are deeply indebted to a wonderful steering committee of medicine, nursing, social work, community, clergy, and pastoral caregivers who have met together for almost a year in planning today's event. I hope that you will reap the benefits of their hard work in exploring this issue. A few housekeeping details. If you should have any questions during the speaker's presentation, you can add them through the question and answer button at the bottom of your screen. Even if you must leave at 9 a.m., we will have your questions logged in, and we will have a chance to address it in the Q&A dialogue. A recording of the entire event will be made available to all participants. During the Q&A portion, you will be able to offer questions or comments through the Q&A button, through the chat feature, or by raising your digital hands. There is a small raise hand button at the bottom of your Zoom window. The facilitator will call on you and allow you to unmute your microphones so that you can ask your question. This conference is approved for continuing education credit. Eligible participants seeking CME credit, please text 20485 to 888-816-4893 to record your attendance. Through Robert Wood Johnson Barnabas Health, it is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Centers Commission on Accreditation, and by the New Jersey Social Work Continuing Education Approval Collaborative. To receive contact hours for this activity, you must stay until the end of the program and complete the respective evaluation for social work and nursing. The speakers disclose no conflicts of interest, receive no relevant financial support, and will not discuss off-label use of any product or device. We have not received sponsorship or commercial support for this program. Again, I welcome you to the 2023 John Suydam Kuhlthau Bioethics Conference. And without further delay, I yield to the president of New Brunswick Theological Seminary, Dr. Michael McCreary. And after his welcome, Dr. David Cohen will take us further, introducing our speakers and facilitate the Q&A sessions. Again, welcome.
Greetings. I'm Micah L. McCreary, President of New Brunswick Theological Seminary. From the Board of Trustees, faculty, staff, alumni, students, and friends of New Brunswick Theological Seminary, I greet you in solidarity and friendship. At New Brunswick Theological Seminary, we like to say that we live in the light of Isaiah 43:19, which says that the Most High Creator is about to do a new thing. We are thankful for the new thing being done through the John Suydam Kuhlthau Bioethics Conference. We are thankful for the new thing our former board member, Dr. Carol Collier Kuhlthau, and the Kuhlthau family are making possible through their generous support of this ongoing conference. I would like to thank our faculty member, Dr. Reynard Smith, and the Bioethics Conference Committee for their hard work and enduring partnership. Welcome to this powerful and engaging learning opportunity. As the Bishop Desmond Tutu made clear using the Swahili word Ubuntu, we say to you, we are because you are, and because you are, we are. Blessings and grace to you this day.
Thank you very much, Dr. McCreary, for introducing the conference. As a reminder, please use the raised digital hand if you want to ask a question or make a comment. When it's your time to ask your question, I'll call on you and we'll allow you to unmute your microphone so you can ask your question at the completion of the keynote address. You can also put your question in the chat and I'll read them and direct them to the respective presenter. I'd like to, it is my honor actually, to introduce our first distinguished speaker for today, Dr. Dula Pacquiao. Dr. Pacquiao obtained her BSN from the University of the Philippines, master's degree from the Teachers College at Columbia University, and a doctorate in education from Rutgers University, where she is currently Professor Emerita. Dr. Pacquiao is recognized for her expertise in transcultural nursing, culturally competent care, ethics, and health equity. She's received approximately 28 awards for research, leadership, and teaching, including the Leininger Award for Transcultural Nursing Leadership, Humanism Award from the New Jersey Healthcare Foundation, the Lifetime Achievement Award from Rutgers University, Leadership in Professional and Allied Organizations Award from Columbia University, and the Soteo Medal of Honor from the University of Philippines Nursing Alumni Association. She was also inducted into the Master Educators Guild and the Alumni Hall of Fame at the Teachers College at Columbia University. She's established 2 academic centers dedicated to training of healthcare students and practitioners in culturally competent care. She provides consultation to and serves on leadership roles for numerous national and international organizations in developing and implementing initiatives relevant to culturally competent care and leadership. In total, Dr. Pacquiao has published about 130 peer-reviewed articles, book chapters, and books on a range of topics, including cultural competence, ethics, health equity, social determinants of health, and vulnerable populations. This includes 2 recently published books, Social Pathways of Health Vulnerability and Global Applications of Guidelines for Culturally Competent Healthcare. We are very fortunate to have Dr. Pacquiao speaking to us today on intersectionality of diversity, inclusion, and equity. Thank you very much, Dr. Pacquiao.
Good morning. Thank you for that introduction, Dr. Cohen. I am deeply honored to be part of this conference. Let me share my screen so we can start. So the title, as mentioned by Dr. Cohen, is The Intersectionality of Diversity, Equity, and Inclusion. Sorry. I want to start with my objectives. I have 3 objectives, and these are analyze interconnections of diversity, inclusion, and equity, reconceptualize cultural competence within the concept of diversity, inclusion, and equity, and identify culturally competent approaches to achieve health equity. There are actually very strong drivers of population vulnerabilities. I will mention a few and I will discuss them further as part of this presentation. Neoliberalism is one of the philosophies intertwined between marketing and political as well as economic philosophy. But in America, I think it has intertwined with the main cultural ethos of individualism and the idea of pursuit of one's own destiny, being responsible for one's health and illness recovery, and also the idea that we can benefit and profit from almost anything, including health and illness. Population diversity, with all the migration that is coming across the world, we are seeing more and more diversity in demographics, and we are seeing also people desperate to come because of poverty, starvation, wars, and violence. All of these intensify social inequalities and inequities that really impact healthcare. And the other one is climate change. We now have a new set of refugees, climate refugees, and a new set of homeless people. But I'll go through each one of them. The US is the only wealthy democracy without a universal healthcare. And our healthcare is really neoliberalist. It is market-based, profit-driven. It lacks universality in terms of health coverage, so that we have different tiers of health coverage. We have different contracts based on Medicare, so that you don't necessarily have same services and access based on that contract. Same way goes for Medicaid. It is very tough, truly, to be poor in this country and to be less educated, because it takes an educated person, a very literate person, to even understand the marketplace and the different multiple payer system that makes so much money out of our healthcare. Different vendors. We have the most expensive healthcare in the world, and yet we don't cover everyone. And our health outcomes are nowhere near those wealthy nations comparable to us that have universal healthcare. And one of the biggest reasons for this lack of universality is that this idea of competitiveness among multiple payers, secretive contracts with vendors and providers. So this is the reason why our social inequities is probably rather include our basic healthcare infrastructure, the lack of universality in terms of health coverage. So because we don't have those kinds of universal coverages, our own infrastructure of healthcare violates several ethical principles. One is doing no harm, non-maleficence. Think of people who are uninsured and underinsured. It is really tough to be sick. And access to even preventive care is very limited when you don't have access to healthcare. Beneficence. How can we benefit when the main criterion for what we do for you in the hospital or in healthcare is based on the kind of coverage that you have? Your discharge, your treatments, these are limited according to or set by the contracts that are provided by your insurers. Human rights. When we have 26 million, over 26 million uninsured Americans, and about 43.4 million, percent of adults are underinsured, we violate human rights access to healthcare and quality care, especially when they need it. And the ethic of care, the idea that what we do is supposedly to advocate and discover those recklessness and unfairness in what we do for others, we violate that too, the ethic of care. And autonomy when we don't have the facility for promoting health across populations, we violate the capacity of the individual to develop his or her own potential. And worst of all is the violation of justice. Healthcare, according to Martin Luther King, when there is the worst injustice, is the lack of justice in healthcare access. So we know about social determinants of health, although these are conditions in which people are born, grow, live, work, and age. We do know that healthcare infrastructure is one of those components that truly make an impact on whether you have potential for good health. And social determinants have social and physical environments. Social would be our relationship with each other. So the ideas of exclusion, discrimination would be under that. Physical environments would be when you are powerless, you end up living in poorly resourced environment, very deprived of same conditions that would promote quality of life. And these include both social as well as physical environments that extend to our neighborhood and built environment. So socioeconomic factors are generally defined as education, income, and occupation. And they do parallel the environments where we live. If we have poorer SAS, we are likely to live in poorer physical environments. So while these are non-medical factors, as I said, healthcare infrastructure is one of our biggest problems in this country. And how do social determinants get into your body? How does social class get into your body? Nancy Krieger from Harvard University proposed this idea of embodiment of ecologies. That in fact, the place, our social place and physical places impact our health. So that our bodies literally are the maps of our experiences with both our social and physical environments, and they stem from historical, structural, and infrastructural forces. We all are familiar with the famous Whitehall studies of Sir Michael Marmot that discovered the idea that social status, in fact, is a greater predictor of poor health and mortality rather than biological markers that we are very familiar with, such as high cholesterol, hypertension, and all that. So our exposure to these environments affects our susceptibility, resistance, and adaptation to stressors, according to Krieger. I like to go over allostatic load because by understanding allostatic load, we need to have the knowledge and awareness and the sensitivity that we cannot blame people for what they are and why they come to us for help. Allostatic load, according to McEwen and his associates, is defined as the resulting wear and tear from too much stress because of inefficient allostasis. You have the inability to turn off the stress response when not needed. So even when you're asleep, imagine all those high levels of stress hormones still governing your body. In return, you have an effective response to stress or not adapting to the same stressor over time. So once subjected to further stressor, you will end up collapsing. And it produces changes in personal behaviors that aggravate allostatic load as smoking, overeating, drinking, poor quality sleep. Think of people, incarcerated people, and there's high incidence of smoking, drinking. And this could be part of the allostatic load effect. It's important for us to know that the perception of stress and how you respond is mediated by the brain. So allostatic load creates effects on the brain, the hippocampus, the amygdala, and the prefrontal cortex. So if the hippocampus is affected, there's a disturbance in your memory and attention. There's imprinting of past trauma or flashbacks. An example is PTSD. You don't need to go to wars in order to experience PTSD. Living in high crime neighborhoods and worrying about how to feed your children the next day and your family. All of these stressors could create imprinting of experiences, and being starved and malnourished are imprinted in your brain. So adverse experiences in early childhood have great impact in adulthood. If the amygdala is affected, the fears and unlearned fears are uncontrolled, promoting anxiety, aggression. Cardiovascular disease also results from hyperactivity of the amygdala. And the prefrontal cortex, which is so important in our decision-making ability, in our control of our behaviors, is also impaired. So we have impaired cognition and learning. Insomnia is part of that too. So in summary, allostatic load creates irreversible changes in hippocampus, prefrontal cortex, and amygdala. And it affects the same mediators that are involved in the acute stress response, only that because stress is unmitigated for weeks and months, you have high levels of these mediators, your glucocorticoid, catecholamines, pro and anti-inflammatory cytokines, and affecting, of course, multiple systems in your body. So you end up with chronic elevation of these mediators, producing cardiovascular disorders, HTN, your hypertension, heart attack, and stroke. Cardiovascular disease may result from stress-related amygdala hyperactivity. Sleep deprivation produces increased evening cortisol, insulin, and blood glucose, elevated blood pressure, reduced parasympathetic nervous system response, elevated pro-inflammatory cytokines, and increased gut hormone ghrelin, which increases appetite. So all of this depression in immune response, depressed mood, obesity, diabetes, PTSD, mental health problems. It's no wonder that when we are exposed to the social conditions and we have the ability to access healthcare and quality healthcare, we have health disparities. It is not a surprise, therefore, that the same groups of people with the same poor social determinants of health end up with increased disease burden and burden of mortality in all categories of illness. So for today, we're talking about the DEI. I call it DIE because the inclusion is really at the middle. So diversity, if we understand it, are differences including varied demographics, perspectives, approaches, and competencies. In fact, diversity is the basis for all the inequities in society. And they may be traced historically, as well as traced through our social structural conditions. Inclusion is the mechanism or the process for accepting differences among us based on the core values of respect, fairness, and sense of being valued sense of belonging and being valued. And there are many aspects to that inclusion. Before we can even get into inclusion, there are many things that happens. So in the next few slides, I will unpack what inclusion requires. Equity is supposedly absence of unfair, avoidable, and remediable differences among population groups defined socially, economically, and demographically or geographically. Now, equity talks about outcome. So equal access need not produce equity in outcomes because some groups need more help than others. So if we just give equal share, it doesn't assure equity in outcomes. So that's very important to understand about equity. What is required then for inclusion? Social justice. The theorist of justice, John Rawls, said that people in a society must make choices in order to protect those who are in lesser position in society. A just society, according to Rawls, is where the most vulnerable are rendered less vulnerable. So think about those on Medicaid and those uninsured and those that are inadequately insured. The US literally is the best country if you have good insurance. But very few people have access to that. Singh and Associates mention the idea of social justice identity is the internalization of the values of social justice and acting to foster social equity and paying attention to human rights, beneficence, and an equal concern with material and non-material aspects of justice. Non-material justice involves rather goodwill, kindness, respect, all these values, ethical values that really are important. But understand that we can only do so much at the individual level with those virtues of respect for people's rights and dignity if we don't have the social infrastructure that support our ability to be more effective in providing the non-material aspects of justice. Many of that we can do by ourselves, and that is probably something that is inculcated in our schools. Ethics is very important, especially in today's age, as we compete more and more for scarce resources, highly competitive economy. So from virtue ethics, we learned about empathy and compassion, and Nussbaum talks about this as something that needs to be intertwined. While empathy is the cognitive piece, understanding what it's like to be in other people's experience. Compassion, on the other hand, is the feeling piece of it. You need both to be compelled to action. So in social justice, internalization, you need both compassion and empathy. Because learning about the suffering of others may not necessarily compel you to act. But when you feel the suffering of others, it is very important. It is more likely that you will be motivated to do something. So compassion very often is not learned in the classroom. It is learned through experience. I would like really the idea of putting healthcare professionals to go make home visits, enter vulnerable communities and see how they live. Only by sensitizing to the idea how much they fear getting out of their apartments, for example, because there's drug dealers outside and a lot of gun violence in the community, you will hesitate to say, please walk every day. When it's a nice day, go out and walk. You need to understand why people don't do that. So you may have to alter your health teaching. Okay, let's look at the corridor in your apartment or maybe within your rooms in the apartment. Just see how far or how many times you have to walk back and forth. So we need to have the practical experience because of our experiencing the actual conditions of their lives. And you can only do that by exposure to vulnerabilities of people and their environment. The other one is the ethic of care. See, caring really is relational. It's making connection with others. And how you present yourself and the goodwill inside you must be obvious to the people that you are caring about. And we need to respond in relationship by attentiveness, listening, sensitivity. Because without that, people won't trust you and they're not likely to attend or adhere to what you say. And it's grounded in a psychological logic, reflecting the ways in which we experience ourselves in relation to others. So when you get exposed to vulnerabilities, you begin to understand what it's like to be one of vulnerable people in certain circumstances. So it's that compassion that comes and pulls the idea of, I can relate with you or I can relate with the situation. So relatedness with others. Self-care is not as good unless we relate with others because we live in the same world and their problems are our problems. I like the idea of cultural competence. The guru of cultural competence, Madeline Leininger, defined it more as ethical care. She said the cultural congruent and competent care is meaningful, beneficial, and enabling care that ameliorates human conditions or lifeways. So in this slide, I have the three categories of what cultural competence might be that goes into social justice and goes into population health, going beyond or a little bit beyond just individual-based care. So you need self-awareness of vulnerable and powerful groups. We need awareness of social policies and how they impact on vulnerable groups, especially healthcare infrastructure and policies, and ethical principles, of course. The skills are cross-cultural communication, and I will add building social capital. Bonding is the bond of people that are close-knit, such as families, your relatives, your professionals that you work with. We bond with each other. But in working with communities, in order to foster greater power among them, empowerment is bringing more communities together. So when we move horizontally from one community to another, we bridge and we build social capital because we see similarities and differences in them. And they also see similarities as well as differences in them, share their own skills and expertise if they have any. But the most important is linking. I think part of health professional behaviors would be fostering linking capital. This is the vertical bridge between communities and experts, outsiders to the community that could truly bridge the ability to change social policies. So advocacy, empowerment, mediation, and the attitudes, cultural humility. I will mention dispositional humility, reflexivity, which is the ability of correcting oneself because we know better. You don't need to be told by everybody that you are discriminatory. You need to be reflective of your own behavior. Respect, compassionate empathy, and social justice identity. So why do we need dispositional humility? Because we need to collaborate. We need to collaborate with diverse people, people who don't understand the way we do, people with less resources than we have, so that we can go at their level, we can go lower, and we could go high level when we're talking to policymakers. Cultural humility to me is good when you're talking to vulnerable people, but once you're faced with politicians and you're trying to advocate for change, I think humility should go out the window. I mean, that's what we need to show communities, that there's a place for being humble, but there's also a place to really put forward and be more confident about what you say. Dispositional humility allows accurate self-assessment, openness to new ideas, appreciate the contribution of others, and generosity. And they combine leadership, spirituality, I would say, cultural and relational attributes. So here's the social capital from Purdue, which I was talking about. So within networks is the bonding capital. That's easy to foster. But the study of Robert Putnam, for example, showed that when the community have mutual reciprocity, they trust each other, they share their problems with each other, and they share caring for each other, they have good resources within themselves. However, in poor communities, very often this sharing probably has to do with emotional and in-kind sort of sharing. They need help with other resources. By bridging communities horizontally, these are between networks now, you actually empower them because now they can command better audience from policymakers. But the linking is where we come in. We are bringing expertise. We can translate in numbers the problems and concerns of the neighborhood. We can do statistics, and we can present in a rational way to politicians and funders to provide resources that are needed. This is a new skill that I think should be taught in all healthcare professions. Health advocacy is another skill, encompasses direct service to the individual or family as well as activities. Advocacy is very important, but very often is directed by the other, by the healthcare professional. Empowerment is more important because in empowerment, it is a process and an outcome in which individuals and groups act to gain mastery over their lives in the context of changing their social and political environment. So it requires really further work in the community, a rather prolonged exposure to vulnerable communities. Empowerment, according to Freire, Paulo Freire, the person who originated the idea of empowerment, you are not empowered unless others recognize your power. This is why working in communities, building relationships across groups, it's very important in empowerment. You cannot be empowered just as an individual. People must recognize that, in fact, you have some power. So mentoring and working with communities is extremely important. So that in teaching, for example, our professional engagement, our cultural competent care approaches, we need to think at 3 levels. We always do one-on-one in terms of our care because people get sick and they come to you. At most, we see their families accompanying them, but most of the time it is at that individual level. But they could bridge they could bridge communities with us through these individual connections that we have. The next one is to work at the meso level, the organizational level, by engaging our organization and engagement with our organization in collaboration with outside community. You know, if you are in power within an organization, please ask questions like, how much of our budget is being used for the uninsured and the underinsured? What do we do for communities that are living in deprived environments? And what are sustainable outcomes that we expect? And have we gotten those things already? And of course, the macro level, societal level, which requires multidisciplinary intersectoral collaboration to transform communities, environments, and laws. This is the linking capital. We need really to involve ourselves in our communities, not just the good ones, but vulnerable communities particularly. And in research, I want to mention this because we can only prove to policymakers if you use data sets, large data sets. And we need to learn a skill of secondary data analysis, looking at those data that are collected for us. When you convince people about a problem, if politicians about problems, it's better to have a cross groups approach rather than just a particular family or community. Health in all policies, we need to examine policies and their impact on health. So another skill is systematic reviews. Community-based participation research and doing mixed methods research. Because with qualitative, you can get the reason sometimes why the numbers come out in quantitative data. And in research, you must always include environmental factor as a study variable. For example, in one study from the UK, they found that people commuting from work gained weight because of frequency of eating fast foods. But they included, for example, how many fast food restaurants or outlets are there within the commuting area of these office workers. And they found that the greater the number of fast food restaurants, the higher is the consumption and the higher are the levels of cholesterol and weight levels. So if we did not include the numbers of fast food restaurants in that study, we will only limit our health teaching to changing individual behavior. But because we knew the environment also supports bad behavior, we will go then into policy change. Can we control zoning of fast foods? And popular epidemiology is rather including community members to collect the data. For example, how many times did their garbage not be collected when they called the police because of crimes in the neighborhood? How long did it take them to respond? That's exactly popular epidemiology, and they can very well do that for us. So with this last slide, I really like the idea of Heidegger, who is an existentialist philosopher. His idea of Dasein, being in the world, it's the German word for existence. And what Heidegger is saying, that care is the basic structure of the inseparation of connectedness of human beings with the world. We need to act otherwise, according to Lynch, rather than self-wise, so that in our care for individual patients, understand that they are part of others, they are part of the world. So caring underlies all life-sustaining activities that maintain and repair the world. If we pollute the world, air pollution does not pick whether you are rich or poor. We all breathe the same air. So this act of social repair, reaching out to those in the community for whom things are broken down in an effort to redistribute opportunities. So in other words, if the governments fail to do things, we need to put that responsibility for us, for ourselves, to care for others and seek resolution for their problems and concerns. With that, I think I can skip this one And that's the way, I think, to do equitable health practices, that we focus on upstream and we focus on population, not just individuals. We focus on health rather than disease, and it makes sustainable, equitable changes in the community. Thank you.
Thank you very much, Dr. Pacquiao, for that wonderful talk. Dr. Pacquiao, I would like to ask the first question. You are a distinguished educator. For those of us who work with learners, and our learners are already overworked, as are we, many of us, and many of our learners feel as if they've heard enough about health equity, DE&I, and social determinants of health. Can you provide any advice to the educators in the audience how we can engage and teach our learners about these essential topics?
I think part of that is choosing the clinical experiences of your students, and that can easily be done in the curriculum. I would say take more your students to the community. Why couldn't they go with a visiting health nurse? Visiting nursing agencies that could take them to the homes of patients, put them in real situations of patients. I used to make home visits in projects, and I realized that I feared for my life. I would visit at 7 a.m. just so before the drug dealers would come out on the streets. And when you go in, you need to be practical about what you tell patients, because you can't even do it yourself. So I think it was the philosopher, the postmodern philosopher Foucault, did say that the worst thing we do to medical training is concentrating them in the hospital, which is the territory of the doctors. You forget to see the context of patients' lives. So it's not so much that they are busy. I would say plan it so that their clinical exposure does not limit them to areas that they control, but rather in areas that patients truly live in.
Wonderful. Thank you so much. Our next speaker is Mr. Jeffrey Grosser. Mr. Grosser serves as the Deputy Administrator of Health and Community Services for the Municipality of Princeton. Also serving as the Licensed Health Officer, Mr. Grosser is responsible for the administration on public health practice standards in Princeton. Under his leadership, the health department became only the third local health department in New Jersey and one of the smallest in the country to achieve national public health accreditation in November 2018 through the Public Health Accreditation Board. During Mr. Grosser's time with the health department, he has overseen notable communication disease responses, including Ebola in 2014, measles in 2015, and COVID-19 from 2019 to 2021, while improving community partnerships. Prior to his time in Princeton, Mr. Grosser worked for the Burlington County Health Department. He began his public career as an environmental health specialist and finished his time there as program manager of disease prevention and control. Mr. Grosser also served as a lieutenant in the United States Navy Reserves as an environmental health officer. Beyond governmental public health, Mr. Grosser has served as an adjunct faculty member at Stockton's University School of Health Sciences since 2013. Mr. Grosser's professional experience includes intersectional collaborations between health and social services. His public health approach combines community needs with mid to long-term improvement plans in order to create the best possible health outcomes. He is a 2010 scholar of the Northeast Regional Public Health Leadership Institute, as well as a 2011 fellow in the inaugural cohort of the National Leadership Academy for the Public's Health. Mr. Grosser, thank you for your service, and we welcome you to talk to us today about ethics in community health, ensuring equity for all.
Thank you again, Dr. Cohen and Dr. Pacquiao, for that tremendous keynote. I think this is going to be a good launching pad for this presentation where we're looking at ethics in community health. I'm very excited to be with everyone to discuss this topic. I'd like to start off by thanking the New Brunswick Theological Seminary, Rutgers Robert Wood Johnson Medical School, St. Peter's Healthcare System, and Robert Wood Johnson University Hospital I'm honored to be one of the keynote speakers for the Honorable John Suydam Kuhlthau Bioethics Conference. I'm a strong believer in what this conference stands for with regards to medical ethics, along with providing workforce development training to promote learning, best practices in the delivery of ethical medical care. I trust that we'll all gain knowledge and wisdom from this morning's presentation and then follow up question and answer. Our presentation this morning will follow this outline. We'll review the objectives of the presentation again, as it was originally mentioned at the beginning of the conference, with the overarching purpose of the conference. And then we'll discuss what community healthcare is and what that model consists of. How we apply this model in Princeton will be reviewed with some other cities and towns throughout the country with best practices. And we'll sum up the presentation by discussing benefits and challenges to our current approaches while concluding with recommendations for the future. At the end of the presentation today, we should be more familiar with the following objectives. First, we should be able to define equity and community healthcare and how it's relevant to the delivery of healthcare in general. Our second objective will lay out the components of equitable community model and how they're applied in best practices. And last but certainly not least, we'll demonstrate how a framework of a diverse and inclusive workforce is necessary for equitable healthcare. Getting right into our first objective, we'll now review the core principles that make up equitable community healthcare. Equitable community healthcare is a framework designed to ensure that all individuals have access to healthcare services regardless of discriminating circumstances. It does so by inviting community voices to the table when creating solutions to care. Overall, an equitable community healthcare model aims to create a healthcare process that's not only effective in treating disease, but also fair and just in its distribution of resources and services. Paula Braveman, founding director of the Center for Health Equity at the University of California, San Francisco, and a health equity expert, sums this up perfectly by stating, "Health equity means that everyone has a fair and just opportunity to be healthier. This requires removing obstacles such as poverty, discrimination, and their consequences, including powerlessness, and a lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare." Ms. Braveman's comments resonate with my office at the Princeton Health Department. Our staff, particularly those pictured on this slide, will actually seek out obstacles restricting healthcare access to residents, just so we can help residents overcome them. They understand that barriers will always exist in some form. It's our job as community health specialists to educate the residents on ways that they can overcome them, hence getting through the powerlessness, but when necessary, allow us to work together to get around or over those barriers. Equitable community healthcare can also be contextualized in a series of models, as seen in the next few slides, along with examples on how we've been successful in Princeton. Again, pictured on this slide are some of our local health department staff doing just that with some of our close community partners. In the graphic shown here, we have the community engaged healthcare model. This model comes from research that can be found in the National Library of Medicine on community healthcare models for underserved individuals in the healthcare system. At its core, this model identifies a relationship between health professionals and community members who are key players in the community health system. And for the purpose of this morning's keynote, we're going to focus on the left side, which is the healthcare system ecological model. Here we can see the relationship between the healthcare system, clinics, interprofessional teams, and community health liaisons. Their relationship is transactional and bidirectional in nature, meaning that each key player influences the other, and together they serve to support the community. Now, it's important to remember that this is only effective when the co-creation of the health system is truly collaborative and not superficial. There must be a true shift in power where health providers invite, and I have to stress that word, invite, community members to the table when deciding how to address health issues. This gives community members the power to make change that are appropriate for their own people, whether it's in terms of culture, language, accessibility, and other deciding factors. It's also important to note that this model is only one component of a larger idea, which encompasses the relationship between individuals and their environmental systems, as Dr. Pacquiao put in her keynote, such as family, school, work, and culture. And we have to keep this in mind because behavior, especially the motivation to engage in positive health behaviors, is highly dependent on those levels of influence. And it makes sense now to most of us, I'm sure. Much of our health behaviors over our lifetime have been formed by family, such as role modeling of parents and immediate family members through values or beliefs, through school, where we see formal education of health and wellness, and of course, peer influence in our social environment, as we definitely see with some of our adolescents, through culture, where we see norm-shaping dietary preferences, physical activity levels, perceptions of health, and through stigma and healthcare beliefs. And as we've certainly found out through the pandemic, our work environment can impact health behaviors through things like job-related stress, work hours, and access to health resources or wellness programs. As a whole, the community-engaged healthcare model addresses health inequities through the lens of the community members impacted by them. The next model comes from the Centers for Disease Control Community Health Improvement Navigator, which is an online resource for hospitals, healthcare systems, public health agencies, and other community organizations to identify and address the health needs of their communities. In this model, we look at the basic components of an equitable community healthcare system, and we look at the answers of questions of what, where, who, and how. And in order to establish a system of care that minimizes health disparities and improves health outcomes for all populations, it's vital to focus on the health issues impacting your area, whether they be chronic disease, injury, obesity, but we also want to look at the factors that are influencing those outcomes. Then you have to pinpoint the streets, neighborhoods, and areas of your community that are the most impacted by these issues. And once you have these data points, you can invite those community partners to collaborate on effective solutions, which we've discussed in the previous slide with the community-engaged healthcare model. Partners that you can invite from the community include food pantries, schools, businesses, churches, and individual community advocates who have a strong presence and trust in your area. As I mentioned previously, the collaboration with these organizations has to be meaningful in order to create a true community healthcare system. Through conversations, meetings, and even email threads between these groups, the ideas for interventions are formed. We found that weekly update emails to community partners not only helps them stay informed in what we as a Princeton Health Department is doing, but it also establishes a convenient form of communication where they can ask questions, express concerns, and share ideas for future community events. These are often creative solutions that can be outside of the traditional methods of providing care, but they must take into consideration in the social determinants of health in the community, behaviors and motivations of the populations, the environments that they live in, where they go to school, where they work, and then obviously the clinical care options that are available and accessible to them. A major action area we've seen the greatest impact in the health of the community is in prevention. Programs in prevention are often cited by RWJ Foundation, CDC, Prevention Institute, and other public health institutions that have a high affinity towards equity. Transitioning from the theoretical, we're going to zoom in on the local context a little bit to demonstrate to the panel here, landscape of equitable community healthcare right here in Princeton. Before we get into the actions of our department has taken regarding the delivery of public health services, we're going to provide an overview of some of the key characteristics of our town. The municipality of Princeton is located in central New Jersey, Mercer County, has a population of just over 30,000 people. We've seen this number increase in the last 10 years by about 10,000 residents. Looking at some key population demographics, 60% of residents are white alone, 16.5% are Asian, 6.7% are Black or African American, and 6.3% are Hispanic or Latino. We have some other smaller percentages, but these are the largest of those. And the next slide will look at the importance of recognizing neighborhoods and some of that street level data, and particularly areas where the concentration of racial or ethnic groups plays a big part in public health service delivery. Here, we're going to zoom in on one of the more densely populated neighborhoods in Princeton, and by far the most diverse in terms of population demographics, is a neighborhood called Witherspoon-Jackson. The Witherspoon-Jackson neighborhood has a rich history marked by significant changes in population demographics. The largely residential area has been a cradle for several emerging ethnic groups, notably the Italian and Hispanic communities. However, the dominant character of this neighborhood has always been the African American community. And the distinct history is unfortunately rooted in the history of discrimination and segregation. African Americans have been a sizable part of Princeton's population since its inception. They interacted primarily through various vocations with predominantly white permanent and student populations of Princeton. And for much of this time, Princeton's African American population, including slaves and former slaves, faced racism in various aspects of life. And the discrimination led to the creation of the Witherspoon-Jackson neighborhood as it exists today. This history of discrimination deeply impacted various aspects of African American life in Princeton, which resulted in social economic disparities that shaped this character, including its people, history, architecture, and streetscape. The neighborhood remains significantly distinct from the rest of Princeton, and recent decades has seen a gradual dismantling of this racial divide. But nonetheless, it's been a testament to the incredible perseverance of Princeton's African American community. Now, recently, there's been an influx of Hispanic Latino residents into this neighborhood, which signals a broader demographic shift and reflects the changing face of Princeton. The shift may have been driven by factors such as economic opportunities, education, and cultural attractions in the area, but it adds to the neighborhood's rich tapestry of cultures and contributes to the ongoing transformation of the neighborhood. And as a result of this transformation, it is experiencing cultural enrichment and diversity, underscoring its significance in the evolving mosaic of Princeton's community. And it continues to be one of those areas that we have most of our vulnerable population in Princeton, which I'll get to in the next couple of slides in terms of how that service delivery has come that way. So looking at the health outcomes within our community, before we get into the health needs of a community, we have to know what we know about the community. Our staff are regularly listening to residents about their needs, and we're definitely reliant on health metrics. But there's always been in public health somewhat of a shortage in the acquisition of local health data, that streetscape data that I was talking about earlier. Most health data is collected on a county or regional level, which causes public health professionals to miss out on that zip code level streetscape data. And that is prior to the evolution of something called the City Health Dashboard. This dashboard is a groundbreaking initiative designed to address the critical need for comprehensive health data in the city level of the United States. Created by a team at NYU Grossman School of Medicine's Department of Population Health in partnership with Robert Wood Johnson Foundation, the City Health Dashboard was launched in 2018 to equip communities and city leaders with a wealth of up-to-date neighborhood-specific data, such as life expectancy, access to parks, and child poverty rates. The data serves as a vital resource for improving public health outcomes and reducing health disparities. The dashboard now covers over 40 essential health and health equity measures for more than 950 cities across the United States, including both large and smaller municipalities. Princeton is one of them now. And it was developed with a commitment to continuous improvement, constantly expanding its data offerings and features. It includes the incorporation of multi-year data, innovative data visualizations, and user-friendly data access across and through an API. One of the most significant impacts of the City Health Dashboard has been providing local leaders with a clearer understanding of the unique health challenges faced by their communities and how to effectively address them. City leaders and partner organizations have harnessed this valuable resource to target public health investments in areas with the greatest need, advocate for increased city budget allocations for health initiatives, and design evidence-based community health improvement strategies. And moreover, that the dashboard is making a significant impact in educational settings worldwide. University students studying public health, economics, healthcare administration, and related fields have access to real-life case studies and applied learning opportunities using this data. Additionally, the City Health Dashboard offers educational resources, including specially designed high school lesson plans based on the dashboard, ensuring that the next generation of public health leaders is well prepared to address the unique challenges of urban health. While the data from the City Health Dashboard is useful, it's still a duty of the local health department to collect this zip code level data for surveillance purposes, which proved to be especially important during the COVID-19 pandemic. To examine impacts in Princeton during COVID-19, we felt as a department that it was important to map out which neighborhoods and which populations were being most affected by the virus. During the peak of the pandemic, our grant-funded epidemiologist was able to extract data from our contact tracing efforts to examine the demographic of COVID-19 cases in Princeton. We used Power BI to map the cases and revealed that a majority of our COVID-19 cases were clustered within the Witherspoon-Jackson neighborhood, as you can see. The graphs on the left display COVID-19 cases between various racial ethnic groups in comparison to their share of Princeton's population makeup. This helps to determine where disparity can exist along with other racial groups. For example, if one group makes up 5% of the population, but 10% of the cases, they are carrying disproportionately higher caseload than the other groups. In doing this analysis, we found that Hispanic and Latinos had been disproportionately affected by COVID-19 when compared to all racial ethnic groups. The Hispanic Latino population makes up just 7.7% of Princeton's total population, but represents 50% of all cases reported. And the findings of this data led us to focus our efforts towards Witherspoon-Jackson neighborhood and the Hispanic Latino community to try to eliminate these health disparities and bring resources to the populations most in need. As demonstrated in the last few slides, data has always been a useful tool in the implementation of public health programming, but we've also explored ways in which we can incorporate the community's perspectives when implementing health strategies. Being able to take the pulse of the community to determine their health priorities and needs is crucial to generating buy-in and understanding where the demands are from an outreach perspective. Shifting from a wholly data-driven approach to community-driven programming is a strategy that can be seen in other health departments and counties throughout the country, specifically from the following best practices. In Ohio, the Cuyahoga County Board of Health collaborated with community organizations, local government, and healthcare providers to address racial health inequities. Partnering with the Center for Achieving Equity, they moved from a data-driven to a community-driven approach by establishing an open dialogue, which allowed members from the community to describe the institutional racism they see in their own community, emphasizing shared values and engaging both hearts and minds. In Minnesota, also responding to inequities, the Department of Health released a report to state legislature indicating and identifying the conditions which create inequities in their community and recommendations for reducing them. From this, they contracted with Voices for Racial Justice, an organization tasked with gathering community perspectives and resolving inequities based on community identified needs. They held listening sessions with community leaders to gather this information. In Washington, the King County Health Department incorporated community input into their strategic plan, featuring an equity and social justice guiding principle to influence decision-making and community engagement. Nationwide, more and more organizations, and specifically more and more local public health departments, are realizing the value of highlighting real voices from people experiencing health inequities in order to create equitable health strategies that fit the needs for their community. And Princeton does this in a few different ways, and I'll highlight some of those in the next couple of slides. One of the ways that we found to engage members of the community is through our rapid public health assessment, which is required through our Center for Disease Control Strengthening Local Public Health Capacity grant, which is also funded by the New Jersey Department of Health. Over the past 3 years, we have worked through this assessment to ensure an accurate portrayal of community needs. We collaborate with established community partners in order to acquire this data, but then also to release its findings. Our partners offer unique perspectives, providing a list of community-identified issues and those affected. Through this community-driven approach, the health department crafts an outreach plan based upon what we're hearing from our closest partners, complete with strategies and solutions tailored to address those identified issues. One of those things that's most important from this assessment is that the health department has a lot of competing demands, and utilizing your partners to also come up with strategies for solutions sometimes takes the workload and shares the workload a little bit with the community, which is not only helpful to our staff, but also a very valuable tool to build buy-in. Another way we accomplished this community-driven approach was by administering a health questionnaire as part of our pursuit of the Gold Star in Health from Sustainable Jersey. The questionnaire covered aspects of health in the Princeton community, which culminated in a question asking respondents to select the three top health issues that Princeton needs to improve to become a healthier community. Moving on to our collaborators, I want to shine a spotlight on the key partners in our pursuit of equitable community healthcare and why these partnerships were successful. Community partnerships are vital for the Princeton Health Department's success in achieving public health goals. And as you can see, we collaborate with various partners across all different types of sectors to enhance our reach and our effectiveness. Now we'll get into a few crucial components of a successful collaboration. As we talked about earlier, bringing people to the table is important, but once you bring them to the table, actually collaborating and creating a team is a whole different story. In our experience, we discovered that the pivotal role played by certain individual or organizations within a community, and we refer to these individuals as gatekeepers, who are essentially advocates with significant influence in the community. When incorporating community voices in decision-making and developing health strategies, the key is to identify who these gatekeepers are within a specific population and who you aim to reach and establish a meaningful relationship with. These individuals offer valuable insights based upon their experiences, shedding light on the genuine needs within the community. When forming these relationships with these advocates, a transformational engagement process is the catalyst for amplifying these community voices. The process marks a shift in the dynamics between health agencies and community members, where this collaboration creates a leadership and decision-making role in the planning of health strategies and initiatives. As I mentioned earlier, in the context of the community engaged healthcare model, this transformational process is described meaningful engagement. While several labels can be attached to this process, the essence remains the same. Collaboration, successful collaboration, is required to have an inclusive space where partners work alongside health agencies. With that being said, these relationships have to be built on the foundation of trust for them to be sustainable. Nurturing trust is not a single action. Instead, it's an ongoing process that requires transparency, responsiveness, and accountability. Think of it as an investment in long-term relationships with your community partners, but there's no single universal method to building trust because it's not a one-size-all-fits process. As you interact with various individuals and organizations, you'll naturally develop your own approaches tailored to the needs and communication styles of the diverse gatekeepers you engage with. Moving on from partnerships to resources, we'll take a closer look at the financial aspect and how funding supports our equitable community healthcare initiatives. The recent COVID-19 pandemic response has highlighted the need for surge capacity in the field of public health. Prior to the pandemic, constant funding cuts to public health led to a depleted workforce, inadequate supplies, and a shortage of response plans. Public health personnel continue to be the most valuable resource in an emergency public health response. Well-functioning public health departments are central to building healthy populations. Yet, accurately estimating the level of funding needed to support public health adequately is difficult for several reasons. The primary challenge behind this lies in the inability to agree upon the cost of a defined package of public health services for every state and locality. There are differences in opinions on how to place a dollar amount on the cost of public health. Two of the most popular theories pertain to foundation capabilities, also known as a minimum package of public health services, and the other is rooted in per capita public health costs. The largest lesson learned through the health department's COVID-19 pandemic response is that shared services and shared staff with other municipalities, which is a common savings method in public health, do not necessarily function adequately during public health emergencies, particularly when public health emergencies are impacting each municipality with the same issue on a large scale, as we saw with COVID-19. Most shared service agreements function where a host municipality pays for a salary position and the other shared service municipality offsets that salary. And this staffing model creates somewhat of a push-pull effect where the professionals being overworked quickly, and typically leaves one or both jurisdictions understaffed and vulnerable to unchecked public health crises. In 1914, New York City's Commissioner of Health, Herman Biggs, remarked, "Public health is purchasable, and within natural limitations, a community can determine its own death rate." For years, the United States has elected to purchase clinical care over preventative care. This collision course of these two types of care was magnified by the pandemic. During the COVID-19 pandemic, communities were unable to perform the 10 essential public health functions thoroughly, which demonstrated different communities being disadvantaged. The second theory discussed considers the average per capita cost for public health services. Public health funding provides a dollar amount for determining the minimum package of public health services. Utilizing the CDC Strengthening Local Public Health Capacity grant that I mentioned earlier, Princeton has increased its public health funding to match the median recommended per capita state spending for public health at the dollar amount of $35.77. At this per capita rate, Princeton is able to include public health emergency preparedness and response to its minimum package of public health services, and also allows us to cover the 10 essential public health services throughout the rest of our routine operations. For a more thorough look at our public health funding in Princeton, we've broken it down on this slide. We regularly seek out grants to help supplement staffing, as well as to provide additional funding for various activities or projects. In 2021, the Health Department first received funding from the New Jersey Department of Health through the Strengthening Grant that I mentioned, which initially funded one full-time position, but now funds 2 full-time positions, as well as funding for staff working on COVID-19 or other infectious disease-related activities. It also provides funding for emergency supplies, such as PPE, printed materials, and other necessary items for outreach in the community. And the grant funding makes up a little over 30% of our current funding. Additionally, we received grant funding that helped support 2 part-time public health nurses and further provide us with necessary supplies and provide homebound vaccinations. While grant funding is crucial for health departments, especially ones that are smaller like ours, it also presents us with a struggle that if grant funding concludes, we can be right back to where we started pre-pandemic. We've been very fortunate to have the same 2 full-time staffers under our initial grant within the CDC and DOH funding, which has absolutely increased our outreach in the community. On the other side of things, local public health agencies have struggled to retain staffers, which has continuously gone through workforce changeover, which also impacts overall community health. Another way of looking at our total funding for public health within Princeton can be shown here. The addition of the grant funding discussed on the previous slide represents a 1% increase in our health department budget when reviewing its impact on our overall municipal operating budget of $68.5 million. Although a relatively simple slide and chart, it does express the power of increasing public health funding, even if just by 1% for an overall budget and the positive change that can come with that. Again, just to reiterate, that 1% increase created 3 full-time public health employee positions that all focus on community outreach and 1 part-time employee whose position is rooted in community vaccination and nursing. As a result of the COVID-19 pandemic, and thanks to CDC and New Jersey Department of Health funding, the Princeton Health Department has been awarded nearly $1 million in funding over the last 3 years. And in total, New Jersey local public health departments have been awarded well over $100 million through the pandemic response, recovery, and community health outreach. Moving forward, we'll look at steps Princeton takes to implement equitable community healthcare. Looking at the actual community healthcare strategies we've developed and implemented, it's clear that in order to better address health issues in Princeton, our department needed to continuously implement community healthcare strategies that aid in providing better health opportunities for residents. We found that over the years, especially during the pandemic, these methods help gauge populations. I'll briefly go over these here to introduce them, and then we'll dive into them a little bit more in the next few slides. The first one being vaccine clinics being offered in a variety of locations for different vaccinations. We repeat locations that we've found to be successful in vaccinating different groups, and we revisit locations to provide different types of vaccinations. Health education. Keeping up with emerging diseases and public health issues have proved to be crucial within the community, particularly with different populations that may have different experiences with those particular diseases. Community development block grants. Once again, utilizing grants can help provide resources to better serve the community. And again, we'll discuss that a little bit further in the next slide. Utilizing health and all policies to educate staff and make informed municipal decisions. Utilizing community health providers. We promote health services through community health clinics like Zufall, which is a federally qualified health center, child health conferences, as well as looking for additional funding through grants. And last but not least, diverse and inclusive workforce. This relates back to one of our objectives. We'll go into some strategies for how to expand a diverse, inclusive workforce, including the importance of creating an organizational plan. Looking again at the first strategy here, community vaccine clinics. Over the course of the last 3 years in response to the COVID-19 pandemic, we've implemented community-based vaccination clinics within the Witherspoon-Jackson neighborhood. While the majority are hosted at La Mexicana, a local bodega, there have also been other clinics at other locations accessible to residents who live in the neighborhood and may not have access to a vehicle. As you can see from the pictures in the slide, the clinics have been on various dates as well as various times, allowing us to vaccinate day laborers as well as generate community trust over the years. Some of our clinics would start as early as 5:30 a.m. or as late as 9 p.m. in order to capture individuals that may work longer hours than others. Our community clinics are how we are able to access the populations who are not engaged during the vaccine rollout. Our strategy was to bring the vaccine to the people rather than to hope that they will come to us. We were able to provide targeted outreach to specific population groups who had low vaccination rates and were at a higher risk of poor COVID-19 illness outcomes. The majority of the population groups who frequent these clinics are under or uninsured, immigrants from mostly Spanish-speaking countries who do not speak Spanish, low to moderate income, and under-resourced in other ways, such as not owning a personal vehicle. These clinics started during COVID-19 vaccine rollout, but since then, we provided influenza vaccines at no cost to uninsured Princeton residents and offered access to other services such as our municipally funded child health conferences at nearby Capitol Health. In total, at this location, we provided 13 vaccine clinics over the last 3 years and provided over 640 vaccinations. To assess the impact of the La Mexicana vaccine clinics, our epidemiology intern mapped out addresses of attendees at the clinics. And as you can see, the addresses of individuals vaccinated at the La Mexicana clinics were concentrated in the Witherspoon-Jackson area. This was a direct result of responding to a health disparity in the Hispanic Latino population by bringing the clinics to areas that were accessible. Comparatively, no other clinic had such a high turnout from this neighborhood. It demonstrates the importance of following the data initially to address health disparities and then following up to assess the impact. But it also demonstrates the impact of using a community engaged model to leverage community trust and meet individuals at a place, both literally and figuratively, that's accessible to them. In this scenario, the owners of La Mexicana were gatekeepers who were trusted in the community and offered a reliable, familiar location for residents in the neighborhood. Aside from vaccination, our outreach team has also curated a variety of health education materials in both English and Spanish that are shared at various outreach events, vaccination clinics, and on our website. Here are a few examples. Health education is of vital importance when considering equitable and ethical care because it makes sure that members of the community are well informed on health topics relevant to their own well-being. The team has always been cognizant of making sure health education materials are accessible, easy to read, and easy to understand to ensure that community members of all literacy levels are able to make informed decisions about their health. It includes our own Princeton Health Department healthcare roadmap. Recognizing that access challenges go beyond translations, we created a comprehensive guide designed to assist residents in navigating free and reduced cost health services for under and uninsured individuals in the Princeton area. The resource guide formalizes an informal network of local providers and presents all available options in a simple yet detailed layout with definitions of key health terms. The goal of this is to empower the community with the knowledge and resources they need to take control of their health. Health education, we know, goes well beyond brochures and standard flyering and tabling. It's also important to explore creative ways to engage the community and provide education. A shining example of this is our 2022 Mayor's Wellness Campaign. The Mayor's Wellness Campaign is an initiative led by the New Jersey Healthcare Quality Institute. It aims to equip mayors and community leaders with evidence-based tools and strategies to enhance residents' well-being, fostering healthier lifestyles and overall community health. In 2022, we partnered with the Arts Council of Princeton, as well as the Princeton Public Library, Princeton Senior Resource Center, and Princeton Care Center to provide free community watercolor classes and book discussions to address mental health. We also performed a social isolation post-pandemic program where some of our older population performed watercolor paintings, as you can see on the slide, which was a major hurdle to get people out of their home right after COVID. But it was a tremendous success. And again, through the Mayor's Wellness Campaign, he also participated, which also brings additional people to the table. As part of our community healthcare approach, we implemented programs funded by our community development block grants in response to community identified issues, particularly post-pandemic concerns. We designed programs to address them. Notable examples include the COVID-19 Personal Protective Equipment Program and Free Vision Dental Care Program. We were able to provide the community with PPE bags that included materials like COVID-19 test kits, oximeters, thermometers, tissues, amongst other supplies that would help residents who are experiencing COVID-19. Also, meeting the consistent demand for affordable vision and dental care among low and moderate income residents, we looked at creating a free vision and dental program for those individuals funded through HUD funding through the CDBG program. From the previous slide, in total, that CDBG funding was able to provide 217 PPE bags and provide free vision and dental services to 52 low-income residents. One of the first coordinated attempts at institutionalizing equity through community decision-making has come from the Health in All Policies approach, from its origins in international agreements such as the 1978 Alma Ata Declaration and the 1986 Ottawa Charter. Princeton became one of the first municipalities in New Jersey to obtain and fulfill the rigorous requirements for Health Gold Star, which underscores Health in All Policies. We did this through engaging the community via online forums in multiple languages, consulting field experts, and making data-driven plans, policies, and interventions. To fill in gaps in services in Princeton, we also established programs and partnerships with local medical providers. A notable initiative is our Child Health Conference, initially known as the Well Baby Clinic, named above as a baby welfare station, dating back to the first clinic held at the Princeton Board of Health in 1922. The rise of pediatrics as a specialty in the United States at that time was in part a response to the devastating infant and child mortality due to unsanitary living conditions, contaminated milk, and inadequate and crowded housing, amongst other problems. The program that we currently run through Princeton, in collaboration with Capital Health, provides preventative healthcare services to under and uninsured children in the area, and is also a state requirement for local health departments to provide. In order to obtain a diverse and inclusive workforce, here are some tangible strategies to ensure diversity and inclusion in your own organizations. 1, ensure that diversity and inclusion is ingrained within the culture by making it integral to the missions and outputs of your organizations. 2, integrate stakeholders from all levels of organization and make sure that all groups are included in discussions to enact and maintain diversity and inclusion efforts. 3, share successes and failures with similar organizations as is in this discourse that will allow organizations to reflect on strengths and weaknesses in previous diversity and inclusion strategies. And lastly, start young. Engage with local communities and schools to ensure that persons from underrepresented groups get early exposure to fields in medicine. Speaking on behalf of the Princeton Health Department, all of these strategies are reinforced within our own workforce development plan. A requirement of National Public Health Accreditation, our plan supports staff training in vital topics such as diversity, equity, inclusion, amongst others, as well as cultural and linguistic competency. On top of those important requirements, the plan also provides goals and objectives for our workforce amongst an ever-changing public health environment. If your organization currently does not have a workforce development plan, the Public Health Accreditation Board provides a great framework, and it's easily replicated across all industries. As we look into some of the final slides, we'll weigh the advantages and potential hurdles that come with the implementation of the community healthcare model. The community-engaged healthcare model comes with many benefits, and here are a few that we've highlighted. Enhanced community trust. This model emphasizes collaboration between healthcare providers, public health practitioners, and the community. By engaging community members in planning, decision-making, and implementation, we demonstrate a commitment to respecting the community's input, which builds rapport amongst our residents. Looking at reducing health disparities, the community-engaged model inherently reduces health disparities because it involves being responsive to the community's needs. Interventions are tailored to populations that are experiencing poor health outcomes and addresses the actual issues in the community. Access to the continuum of care. Community engagement enables healthcare providers to understand the specific healthcare needs of a community. This allows for the development of comprehensive service plans that cover a full spectrum of care, from preventative services to acute care and long-term care management of chronic illnesses, and eliminating barriers to care. When healthcare providers and public health practitioners are uninformed of the barriers their community is facing, it's difficult to understand how to improve service delivery. The community engaged model fosters a deeper understanding of the cultural norms, values, and beliefs of the community, and even common languages, which can assist healthcare providers providing cultural competent care. Looking at some of the challenges, one of the first ones that we've identified is just integration with traditional healthcare models, especially since some of them focus on clinical care and treatment. And on the other side, with local public health, we typically look at prevention, social determinants of health, and community involvement. What I'm excited about is the fact that even on this, throughout this keynote, it seems like those two are starting to integrate even more. Perceptions of personal agency. In a community-engaged healthcare model, active patient engagement is often crucial for success, and community-engaged healthcare models often focus on preventative care and health behavior change if community members have low perceptions of personal agency and believe they have little to no control of their health. This is something that we obviously have to overcome. Resource availability and sustainability. Community-engaged healthcare models often rely on a mix of funding sources, including grants, as I mentioned earlier. And it often calls upon us to rely on volunteers, community health workers, and other underpaid or unpaid staff. And establishing medical homes. This model relies on preventative care and integration with the existing healthcare system. As public health practitioners, we're unable to provide the full gamut of healthcare services outside of the routine services like vaccinations. So obviously the collaboration there with healthcare systems is vital. And as we look ahead, our focus now turns to the future of equitable community healthcare. Shifting the healthcare paradigm for equitable care, we need to make sure that we're deliberate about centering health equity when making decisions about programs and practice. We have to make sure that we reframe health disparities and issues from a community lens. And too often we've been looking at the traditional model being short-sighted, only looking at healthcare from an individual perspective. And as Dr. Pacquiao eloquently stated, it has to be from a population approach. We also have to make sure with the stratification of jobs in the healthcare field, it's important to identify the role of each individual participating in this model. And finally, you have to value the lived experiences of the community in which you're serving. We have to know the community, we have to know what the data is. Dr. Pacquiao mentioned this earlier, and it was not scripted by any means, but the quote from Dr. Martin Luther King Jr. definitely fits this particular keynote. I think we need to make sure that we reflect on Dr. King's words and let us remember that health inequities have far-reaching consequences, affecting individuals, families, and entire populations. And we have to work collectively to dismantle the barriers that stand in the way of accessible, affordable, and high-quality healthcare for all. Thank you.
Thank you very much, Mr. Grosser. That was a wonderful talk, and thank you also for all the work that you've done for our community. We are all better because of the work you've done. We have a number of questions in the Q&A. I'd like to invite Dr. Pacquiao back to join us so that some of these questions may be posed towards her and or Mr. Grosser. So I can ask some of the questions, and I think if either one of you want to join in with the response, I think that would be wonderful for our audience. Dr. Pacquiao, I know you answered this question in the Q&A, but I thought I would bring it back up because it's a wonderful question, and I think you had a wonderful and insightful response. The comment and question is, I have frequently made lectures to our residents and fellows in the hospital to encourage them to consider participating in the care of low income or low resource areas, and they always balk at the idea. How could I continue to encourage my trainees to participate in these areas? I've worked with these communities intermittently throughout my career. Getting these trainees to these areas is difficult because they don't have enough downtime to get out to these areas for a sufficient amount of time to really learn about these communities.
I have two ideas so far that I've written there. it really needs curricular change. You cannot impose extra times to students without some sort of building it as part of their curriculum. So that is really something that maybe for faculty in medical schools to include that be part of their clinical experience. Another one is to create some sort of interdisciplinary course. I've had that. I used to direct the joint PhD program where we had architects, educators, urban planners, physicians, and nurses in my class. It was co-authored by Rutgers and NJIT. And the conversations in the class, I thought, were just phenomenal. Students learning from each other and coming from different points of view. It would be nice to have social workers in the class. And we had residents, for example, of urban communities in Newark. And students really had so much to say. And I've learned as a faculty from the conversations from the students. I know that the collegiate education for medicine, I don't know the name as of now, but they do encourage medical students to obtain global experiences. And what's significant in that is that they find that students who are engaged in global volunteering are also motivated to do or continue volunteering after school. But you don't need to get out of the US. You don't need to go global to reach vulnerable population. It needs to be built in the curriculum.
Thank you, Dr. Pacquiao. There is a comment from Bruce Fisher, who is, I think, echoing part of what you said, or echoing what you said, that this type of activity has to be built into the curriculum. It can't be allocated to downtime, or no one will find the time for it. I think that we all agree with that. There is a comment from Jeanette Goodson. I absolutely agree. This is a moment of learning. They're unknown to increase their knowledge base, compassion, and empathy for communities less fortunate than others. Getting outside the box is an excellent way of learning and providing the services that are truly needed. I guess maybe I'll take that a step further, Mr. Grosser. With the work that you've done, are there any avenues for some of our learners to be involved, or what ways could we encourage our learners to be involved in your work?
Yeah, it's a great question. Thanks, Dr. Cohen, for that comment. I think, in one of my leadership courses I went through for public health, I was taught that leadership is relationships, and the relationships that we build with our partners ultimately have a substantial impact on the community. It's not only me as the health officer that's going to have those relationships, it's also my staff. We get back into workforce being diverse, equitable, and inclusive. The staff have to understand what the mission is, and they have to understand that the population that we're trying to help the most is the population that has the least. And our greatest partners have been those healthcare providers that are seeing these patients on a one-on-one basis and then brainstorming ideas for greater population health outcomes. And as we saw it with the La Mexicana clinics, those interactions directly correlated to enrollment and admission to the Child Health Conference that provided free preventative healthcare, vaccinations for students. We had undocumented residents that were coming in that were trying to enroll in school that had no vaccinations. Making those bridges between the population, the community, and then the healthcare providers to provide those services all comes down to relationships. So how do you begin those relationships? In short, it's the constant communication. As I mentioned, we do a weekly kind of info update to all of our close partners. Although it's relatively static, it does provide an opportunity for someone to see something that might pertain to their relative expertise. And then you reach out and say, all right, what can we do with what you're working on? So that regular communication is key. For the learners out there, I would say, be prepared to discuss things with your local public health department and make those inroads as early as possible, and understand that not every health department is the same. However, due to the recent funding that I mentioned, all those health departments are doing those rapid public health assessment, every one of them. So that there is some uniformity to it that I think that the future medical professionals that are coming, I think that they'll have a much better platform than where we've been the last few years, in part to the sustained funding that's going towards public health and community health.
Wonderful. Thank you. Yeah, I think through your work, we are making, through your work and people who do work similar to yours, we are making inroads, failing a little bit less every day, hopefully. And then Dr. Grosser, from your experience, if you could just touch briefly on the reason for the high incidence of COVID cases among Hispanics.
Yeah, I mean, part of it's their living conditions, as we saw with the infection rate, a lot of, and then also the basically the dwellings that they live within. Many are renting single rooms with multiple people, multiple families within them. So there was no capability to quarantine properly or isolate properly. That led to the higher infection rates, I believe. Also, work-life balance and paid sick leave is another big policy thing that is also getting impacted with, well, we're seeing the impact upon public health because some individuals don't have the ability to take sick leave. And we saw that through COVID. And as a result, they're going to work sick, they're getting their coworkers sick. And then obviously it just continues to snowball. So I think those are a couple of the primary reasons. As a way to try to combat those PPE kits were crucial. We were also able to team up, believe it or not, with the Princeton Theological Seminary because they do have a conference center and a hotel. So they actually assisted us with emergency quarantine and isolation housing. And that was early on. That was not part of the talk. But, again, that was a partnership we had with the Theological Seminary. They were willing and able to assist us there. And it provided an outlet that otherwise we wouldn't have had to provide that safe quarantine and isolation for those types of individuals.
Thank you. And then Dr. Pacchio, bring us back to one of your early points in your talk about allostatic load and its impact on the health of our individuals. In addition to the high incidence of COVID cases among Hispanics, we also know that there was higher morbidity and mortality. I don't know if you can touch on the impact, taking the allostatic load into their high-risk medical comorbidities and then adding COVID on top of that.
I think these are epidemiologists from Canada, Froelich and Patvan. They sort of critique the population-based approaches in Canada, and they're suggesting that it is always better to focus on vulnerable populations in terms of public health programs, because these are the same populations with the highest and more numerous risks in life. So in the event of a public health crisis, they are the worst off. And they said that if you focus on them first, most of what you do will likely apply for the people who are above them. Why? Because they're likely to be poor, they're likely to be lowly educated, they're likely to be working in high-risk industries. Look at those people in the chicken packing, poultry packing industries in Arkansas. And many Hispanics, they say, usually occupy low occupations, and their ability to be health literate is limited. And because many Hispanics are uninsured. A study from Johns Hopkins did find that the initial time of COVID, they did not know that vaccines were even and testing were free. So they were hesitant to go seek help because it might cost them money. And I agree with you, they do live in large extended households. I want to share something. If you want to know healthcare comparison in the world, you should pay attention to Scandinavia. I was there last June, and the driver for our tour guide actually told us that during the COVID pandemic, all the drivers, the taxi cabs and all that, they were asked by the Minister of Health that they need to take healthcare workers to visit patients at home. And I thought, why is that? And to keep the isolation well and to assess probably the local facility for the social distancing and how family members are going to be able to deal with these situations. If you are severely ill, that's when they go to the hospital, but they are assessed at home. So I thought, what a good idea. They had better morbidity and mortality rates, much, much lower than the US. So they mobilized. This is the mass mobilization that is capable, the government is capable of in universalistic insurance system, socialized medicine.
Thank you. Raynard Smith has two questions. The first is something that you've touched on, so you can either answer that again or just focus on the second question, which is truly I think a wonderful question that would be as impactful as any medical or social intervention. The first question is, what are some strategies for providing healthcare to groups that have historically been discriminated and excluded from receiving quality healthcare? And the second question that I was referring to is, how can we overcome the apprehension that these groups have developed over time?
One is really looking at graduating more healthcare professionals that sort of represent their group. Another is, I always say this, but I know I'm increasing more the time needed in the curriculum. We need bilingual healthcare practitioners. I don't see why we should not require Spanish for American healthcare practitioners. Learning a foreign language in adulthood makes you humble because you understand what it's like to learn a new language in adulthood. I mean, how can you build possibly a relationship without talking the language? It is very difficult. To go through an interpreter is very difficult. At least if you know a little bit of that language is a good base to start the connection. And we don't really make that part of mandatory for a country that is so diverse. We don't require a foreign language for our healthcare professionals. I think the verbal portion, the oral communication is very important to learn. And that would be part, but the discrimination piece is harder to teach. I find very often that when I speak about discrimination, that people get very defensive, so that I need to bring it up to the level of being more intellectualized and to use data, I think, to show why is that? Why is it that Native Americans are like this? And then I go back to allostatic load. If you've been enslaved and all that, colonization is total. I mean, if you read the processes of colonization and enslavement, it's the totality of the human being that is affected. You become objectified, you become a thing. I mean, you don't have your sense of identity. I mean, the 60 Minutes portrayal of those Native Americans that were forced to go to Canadian schools, Catholic schools, they were identified by a number. Can you imagine being identified by a number all your life? And not to be told that you can't speak your language, you can't even speak to your own family. I mean, that is severe. So severe isolation and exclusion, and it is so permanent. They become mentally ill, they're unable to be good parents, they're unable to be good partners. So it's a vicious cycle, really, that I think more of this conversation needs to occur. The theory of historical trauma is hard for students to take. That even if the trauma occurred centuries ago or many years ago, and you don't experience it, that doesn't mean that it doesn't affect you at the present time. It's that powerful in terms of its effect. And that's, I think, the idea of bringing compassion, not accusing people, you are, okay, this and that, but I think to maybe give the story a life of its own. Bring compassion.
Thank you. Yeah, I think your point about speaking the language is important, and remembering the difference between an interpreter and a translator, and the importance of somebody who can interpret the language and what's being said, which isn't just translating words that a Google website could do. Mr. Grosser, do you have any thoughts about how we can overcome the apprehension that our historically discriminated and underserved groups have developed?
I think Dr. Pacquiao mentioned it perfectly. I would just add to the language piece that healthcare workers, and that would include public health workers with regards to knowledge of a language. Having bilingual staff within our health department, as small as we are, is vital to make those inroads, as you saw in the presentation. What we found is trust with business community members, especially those businesses that are within those neighborhoods, is another integral part to breaking through some of those barriers, because they can provide, not only a platform to communicate, but also they can assist with earning some of that trust from your organization. It's hard to argue that it's hard to say that anyone would argue that you want the health of your community to improve. And I think if you start with that conversation, with that in mind, typically you'll come to some type of agreement with whomever you're speaking with. Part of the issue, I think, even with the kind of learners on this call, is it can seem overwhelming to think, when seeing patients, that you're putting two and two together with a particular population demographic and what you're seeing, and how to make a larger population improvement. And I would say, keep it simple and do your best to utilize the resources within your healthcare system, but then also don't be afraid to see if anybody within the healthcare system has points of contact in the community. If you're not part of a community health advisory panel, start one. Create something where you can create a forum to bounce these things off of each other and listen to what's going on in the community, because you'd be surprised the more that you talk to people, even though they may not come right out and talk about discrimination or issues they've run into in their communities. And, as being a resident or a citizen here in New Jersey or in our towns, it'll eventually come out, and you'll, when you build that trust, and when that happens, you'll break down barriers with regards to their accessing care that I don't think you've ever seen before. For us, I think the hardest measure sometimes is determining, when residents really just care about survival and food on the table. Sometimes it's difficult to talk about chronic disease and long-term health outcomes because they're worried about tomorrow. They're worried about right now. The goal is to get them to think about the long term. And if they start thinking about the long term, then we've done our job with realizing what the acute health issues are now. If we can take care of those for them, then I think we're going to get them onto a more even playing field with the rest of our residents.
Thank you. Again, I think some of these questions, these are all wonderful questions. There is a little bit of overlap in the content of some of these questions, but I think that I'm sure with both of your experience, we can provide some nuanced answers. How do you address access to care, like the need for primary care or low-income housing for uninsured individuals? And if either one of you can answer this one.
I can hop onto that if that's okay. Regarding access to care, for 0 to 18 years of age, we've done it with regards to the child health conferences I mentioned. That's a state requirement for local boards of health to provide. Again, not every board of health and local health department is created equal. So not every health department has a robust child health conference as the other. So that's also important to know is, our youth in terms of where they're seeking some of those health services, but then also for the adults, typically that's what we're starting to see where, if they have access to an FQHC, that's tremendous. But if they don't have access to one, where are the adults receiving healthcare and what are some of the barriers? We did the survey to talk a little bit about what some of the largest health issues are in town. Most of the towns, I think you're going to realize in New Jersey, have access to care issues. So delving into what are the access to care issues? Is it not owning a car? Is it, mass transit? Is it, what is actually the issue? And then working with your community partners to figure that out. And then with regards to low income housing, again, that's relationships. Does your municipality or your city have an affordable housing office? Are they part of the health panel? Because if you have a community health panel, affordable housing, if we go through the social determinants of health, affordable housing should absolutely be on there because your health is indicated by where you live typically and how you live. And as I mentioned before, with some of our undocumented residents, they are living in situations and conditions that are substandard. And if we don't address those first, it's going to be a very hard battle to get them to start worrying about those long-term health outcomes. So I think from the perspective of the affordable housing piece, find out who your leaders are in affordable housing in your community or your region and bring them to the table when you start having community health discussions and planning meetings, because that should absolutely be part of it.
Thank you. The next question, Dr. Grosser, was directed towards you, but I think, or Mr. Grosser, the next question was directed towards you, but Dr. Pacquiao, I think that you could chime in. The question is, in what ways do you suggest we engage our youth more in becoming involved in healthcare? And Dr. Pacquiao, some of the things that you said, I would extend it to you. How do we engage youth from our underserved minority populations to becoming more involved in healthcare? And as a side note, I want to plug the activities that our medical school, Robert Wood Johnson Medical School, and our Department of Medicine at Robert Wood Johnson Medical School have been involved in extending and trying to improve representation in our students, our minority students for the Robert Wood Johnson Medical School, and minority residents and fellows in the Department of Medicine. So Mr. Grosser and Dr. Pacquiao, I don't know if you have any thoughts about how we can engage our youth and our minority more being involved in healthcare.
Well, the recent Supreme Court decision about affirmative action is a big problem. We need really to attract and recruit deliberately from groups that we need represented. But a big question and a big problem really is the tuition, the pipeline and the tuition. This is why it is very important to start early education, so that those students, in fact, have a good way to make it once they're out of high school. But a big thing would be tuition support. I think I know that I'm really hammering universal healthcare as if it is, but I know it has a downside. But part of universal healthcare system is that we also support tuition of medicine or medical students, and not just that. I mean, if you look at Scandinavia, the college education is free, so that people do have a choice where they go. And that is one aspect that needs to be done. It's really a complicated issue, but it needs to be in the main political debate and discourse. because otherwise we have this patchwork of healthcare in the US. Nobody understands, really. An average person hardly understands what the healthcare is about. How do you select one? I mean, are you even capable of selecting one? Usually we buy food because of our needs, but in healthcare, how do you anticipate what kinds of needs you will have in the future? It takes a very sophisticated person to do that. So I'm hammering with this idea that start with equity in our infrastructure, give equal access, and the education piece also give equal opportunity and access to people. It just doesn't happen unless you make it that way.
Thank you, Mr. Grosser. You have any thoughts?
Yeah, I mean, I think there's a lot of opportunities for, even doctors and nurses and other healthcare workers to participate in some of the early education strategies. There's many school districts that employ something called Skype a Scientist, and they want to learn about the field of science and medicine. And you can speak to students from basically kindergarten through 12th grade and talk about what you do and how you got there. And I think that's important from a workforce development perspective, because it's done so, across the board with students as they're making decisions very early in their educational careers. The other are internships. A lot of public health departments rely very heavily on internships. We have great, relationships with our institutions of higher education, with Rutgers University, Princeton University, College of New Jersey, and we see, several interns coming through here every year where they get to basically volunteer, but also contribute and do sometimes parts of their capstone for their work. And I think they learn a lot about on the job training before they're actually on the job. And I think that that's important to also bolster. But I go back to what Dr. Pacquiao said. A lot of this comes down to very, larger decisions with regards to access to education and, making sure that also our teachers are educated in workforce development. A lot of discussion should be happening in classrooms about career choices, because I feel like far too often students get into college and they're trying to decide a major or determine a career path, which is okay. But I think a lot of that comes because we don't talk about it enough in the earlier grades. So I think that also is another piece of it. And I think from the talent and the expertise, even on this call, there's just so much information and knowledge that can be shared with, the next generation of healthcare providers. And like Dr. Pacquiao said, hopefully we can make sense of the healthcare system and at least shed some light on it for the next generation.
Thank you. We have, looks like one more question, and then we can have a break before the second part of our session today. Should the NJSL be monitored more in those areas where the Hispanic population is more prominent and ensure employers are providing? So I'm not 100% sure exactly what this is talking about, but I guess we can talk about, should our government be more involved in ensuring that our minority population is receiving healthcare, either federally or from employers?
The simple answer is yes. I think there should be, and again, that's that relationship collaboration. We've got New Jersey Department of Labor. We've got the New Jersey Department of Health. We have local health departments. We have local human services offices. We have social services. Those entities all have to collaborate when we look into occupational health for our workers. In Princeton, I think, and this isn't just because I work here, but our other departments, our engineering department, we have a Sustainable Princeton office. They look very closely into occupational health, particularly in some of our day laborers. They look into, different landscaping companies and leaf blower ordinances, and we look into lead paint removal. There's things that we look into. It is a little bit piecemeal. However, we do collaborate and communicate what we're working on to try to improve and enhance the health of the workers.
Dr. Pacquiao, did you have any other
Yes,
ideas?
I know I'm a little off base here. I used to take students to abroad to study healthcare systems, and I took them to Spain, UK, and at that time when we visited Spain, Spain was ranked number 6 by WHO in terms of its healthcare system. And the answer to the question before, should the government be involved? Yes. It needs government intervention. When you are poor without government intervention, believe me, it's not up to private entities to help you. And making that sustainable help is not possible. Spain has universal insurance, and you know how they do it. For every 15,000 population in that town, you are enrolled in a health clinic. Everyone is accounted for. There are specialty clinics, and clinics is not, the term clinic is not used for the poor. Everyone goes to the clinic. We were in a psych clinic on a Sunday, and a patient did not show up, and it was determined that he needed to show up. So the nurse and the physician decided they need to make a home visit. Everyone goes to the clinic, and if you visit the one general hospital in the town, there's hardly anybody in the ER unless there's a car accident of some sort or there's a big festival. But here in the US, just think about that. Unless you enter the system, you're not even accounted for. When you get out of the system, who follows you up? Unless you have your regular private or rather primary physician and all that. But if you are poor, there is no follow-up. I mean, unfortunately. So talking about health disparities should not really surprise us. Why we have some of the worst health disparities? Because we have such a fragmented system. And why employers are taxed heavily in a universal healthcare system. Everybody's taxes pay for healthcare. And you don't have to worry about your premium and all that. Everyone comes out of that pool. So now we have employer-sponsored insurance that doesn't even help you when you get sick and you become disabled and you cannot work. I mean, think about that. Why are we not looking at the whole infrastructure? And it needs to be talked about in the professional circles and really influence politicians. And a universal healthcare is cheaper. Your taxes may be higher, but hey, you don't have premiums to pay for out of your, you don't need to worry about it. They will go up or down. It will go with the rest. And some of those people that are not satisfied with it, they can have options, but at least you got a base that's equal for everybody. It's about time. And at 18% of our GDP, it is unsustainable, our healthcare. We have the highest expenditure, 18% of GDP for healthcare alone. We will be bankrupt someday. It's unaffordable. And I don't know when the time will be. Obamacare, the Affordable Care Act, unfortunately, it's not universal health care. It's the same market-based sort of thing.
Thank you. Yeah,
I'm sorry to dump in the morning.
Well, you talked about your last slide, mentioned the term upstream, and how we can all be upstreamists, and a little bit of increase in taxes to help those who don't receive basic health care is an upstream effect, because it will help us. It may be a short-term increase in cost, but down the road we'll save an immense amount. Well, if there are no questions or comments, I think we can bring the first part of today's session to a close. Thank you again, Dr. Pacquiao and Mr. Grosser for two truly incredible keynote addresses. I can see applause from the audience. You can't hear it, but I can see the applause from the audience. It was truly fantastic.
This is really bringing us to a conclusion in our conference. So in closing, I would like to thank each and every one of you for your contributions to this conference. Your insights, your experiences, your dedication have been the driving force, I think, behind this event. And so may you leave here today with a renewed sense of purpose and a shared commitment to making a tangible difference in your healthcare. I want to thank our presenters, Dr. Dula Pacquiao and Mr. Jeff Grosser. I think they made an excellent tandem team in presenting and addressing this issue. I think Dr. Pacquiao from a larger, a larger perspective, and then having Mr. Grosser bring in almost like a case study of what has transpired in Princeton, Township of Princeton's own initiative in healthcare. And I would also like to thank the steering committee for their help in shaping this conference. So I want to thank, I would like to call out your names because you deserve to be recognized. I want to thank Reverend George Akins, who is from Hackensack Meridian Health Network, for serving on the committee. Rabbi Philip Baisley, from Senior Rabbi of Anshe Emeth Memorial Temple. Dr. Amar Bakari, who I've worked with when I was a chaplain at St. Peter's, and he's been on this committee. He's the chief of the Department of Pulmonary and Critical Care and Sleep Medicine and Associate Chair, Department of Medicine at St. Peter's University Hospital. Thank you to Dr. David Cohen, Associate Professor of Medicine, Vice Chair for Education at Rutgers Robert Wood Johnson Medical School. And then Reverend Christine Davies, want to thank her for contributing. She's the Director of Pastoral Care at Robert Wood Johnson University Hospital. Don Dunn, I want to thank you. Don helped coordinate the CMEs for our physicians. She is the Fellowship Program Assistant, Department of Medicine at Rutgers Robert Wood Johnson Medical School. Reverend Marticia Kennard Dwyer, who's a medical social worker and chaplain at Compassionate Care Amadeus. And Claudia, who will be coming after me, want to thank you for your work on the committee. Claudia oversees the Center for Professional Development, Innovation, and Research at Robert Wood Johnson University Hospital. And Dr. Olivia Rivera Mara, who is the Director of Social Work at St. Peter's University. And Brittany, thank you again, Executive Director of Community Outreach and Diversity Officer at St. Peter's University Hospital. Thank you to a wonderful, wonderful steering committee who helped put this together today for us. And I think that we really benefited from their work on developing this diversity, equity, and inclusion in healthcare. Equitable care is ethical care. And so again, I want to thank all of you, Dr. Pacquiao and Mr. Grosser. Thank you for coming and being with us. And I just think we should just applaud all of our folks who participated in the program. This concludes our 2023 John Suydam Bioethics Conference. Diversity, equity, and inclusion in healthcare. Equitable care is ethical care. Have a good day. Enjoy the rest of your day.